Hello guys, in this video let's do some USMLE step 1 questions. Let me show you how do I approach the questions. Okay, this is the first time I'm doing these questions. Okay, and trust me, this is a good source, so these questions will be like mostly like the concept wise very similar to what you will see in your step 1 exams. Okay, so like of course not the same questions but very similar type of questions will be asked. So if you can solve these types of questions, I think you should not have any problem in your real step exam. So let's start. This is I'm also doing this questions for the first time with you guys, so let's go. Okay, so first thing which I do is read the last line. So a heterophile antibody test result is negative. Okay, which of the following is most likely diagnosis? Okay, so the heterophile antibody test is negative over here. Okay, a 32-year-old man comes to the office because of 2-week history of fever and throat pain. Height is given, weight is normal, PMI is also normal. Okay, you know that it is 18.5 to 24. Okay, somewhere over here. So yeah, it is normal. 24.9, yes. So till 25. Okay, so 18.5, less than 18.5 is anorexia. So this is most of the time anorexic patients will have a BMI of less than 18.5. Pulse is increased, respirations normal, blood pressure decreased. Physical examinations show lymph nodes in the neck. Okay, increased lymph nodes in the neck, axilla and inguinal regions. Okay, there are bilateral tonsillar exudates but no ulcerations. Okay, laboratory results. Okay, hemoglobin, hematocrit is low, leukocytes, my god, normal is 4500 to 11k. Okay, so it is decreased. Platelet counts 1,50,000 to 4 lakh decreased. Okay, this is pancytopenia. Heterophile antibody test is negative, most likely diagnosis. So cannot be EBV because heterophile antibody test is negative. Gonococcal pharyngitis, okay, it cannot be LGV for sure because here there will be buboes which will be painful, very painful for the patient. Okay, and the ulcer itself can be on the genital area, usually penis. Okay, will be painless. So in LGV, buboes painful, lesion painless, nothing of that sort given here. The lymph nodes which are swollen here are in the neck, axilla and the inguinal, but there are no ulcerations, you can see given on the penis or something. So it is not LGV. This is not streptococcal pharyngitis for sure. Okay, because this type of labs will be not given there. Plus in strep you can see exudates. Okay, but the classical finding is not like this. Okay, streptococcal pharyngitis usually young boy, okay, with normal, sometimes leukocytes. Okay, leukocytes will be increased. So no streptococcal pharyngitis. Gonococcal pharyngitis, I don't think so. Most likely the answer of this question will be HIV. In HIV, yes, you can see decreased WBC, that is the hallmark. Okay, so yeah, the BMI, the lymph nodes will be enlarged in HIV. Plus there will be some atypical symptoms like diarrhea. Okay, like flu like symptoms in early HIV infection. So most likely this patient who is young, that is also a indicator of HIV. Okay, with low WBCs, with lymph node expansions or lymph nodes are swollen. Okay, and EBV is negative, most likely the answer will be C, HIV infection. Next question, you can pause the video, guys. Here you can pause the video and try to solve it yourself, and then you can see the solution. Okay, I'm also solving this for the first time, so yeah, but I cannot guarantee, but most of my answers will be correct. Okay, I'll check the answers, and if I'm wrong, I'll mention it down in the comment section. So please view the comments if there is any correction. Okay. Okay, first thing I can see here is MAC. Okay. Immunologic testing is most likely to show which of the following abnormalities in this patient. Okay. A 13-year-old boy is brought to the office because of 2-week history of moderate pain in his left hip and right knee. Okay. He has no major medical illness and take no medication. He's not sexually active. Temperature is high, pulse normal, respiration, blood pressure. Okay. Examination shows warmth of the right knee. Okay. With small effusion. A reminder of the examination, no HIV negative. T2 weighted MRI of the pelvis shows a discrete area of hyperintensity in the left ischium. Wow. Biopsy of the specimen of the left ischium shows osteomyelitis. Culture of the biopsy and synovial fluid obtained via arthrocentesis of the right knee grows Mycobacterium avium complex. Immunologic testing is most likely to show which of the following. Whew. So this is a tough question. Let's see. Absence. So I understood what this question is trying to say. Let's now rule out the options first. So try to read all the options before choosing your best guess. Absent expression of C5. Okay. Bilobe neutrophil nuclei with abnormal granule morphology. Decreased in absolute CD8 T lymphocyte count. Decreased in serum concentration of IgG. Okay. Antibodies. Dysfunctional interferon gamma receptors. Now, this is a difficult question, guys. Okay, let's see. What do I think here is, this is a Mycobacterium. Okay, and we have learned in pathology that interferon gamma and IL-12 plays a role in controlling Mycobacterium, especially TB, but because it is a Mycobacterium avium complex, we can say that this might also work here also. So I have learnt a lot about IL-12 receptor deficiency where you have disseminated TB. So there is a line in first aid, and I know that interferon gamma does interact with IL-12. So my best guess will be this. I don't know the answer. Can be, see, it will be not C5, 100%. Bilobe neutrophils, no. Absolute CD8 count, maybe HIV, they want to go that way, but CD4 would have been mentioned. No, I don't think so. IgG, no. Cell, to control Mycobacterium, you need cell mediated immunity, no humoral immunity. I think the answer is C. You can check the comment section. If I'm wrong, I'll mention that. Next question. Pause the video, okay, if you want to attempt this. Let's do it now. Which of the following is most likely underlying cause of this patient's condition? Okay, 5-year-old. Let's see, is brought to the office by his father because of bedwetting. Okay, so before proceeding, you should know that bedwetting, before, this is what I know about bedwetting, that 4 years is the benchmark. Okay, so 4 years or before, bedwetting is normal. After, it is not normal. Okay, so let's read it ahead. The patient began toilet training at age 3 and achieved daytime continence within 6 months. That's good. However, he continues to have bedwetting episodes uh, at night 2 to 3 times weekly and has never achieved full bladder control. Okay, so this was up till 4. Okay, he has not had any fever, polydipsia, abdominal pain, dysuria, constipation. No, nothing. He's currently in pre-kindergarten. Growth under normal. He's 50 percentile normal. Normal physical examination shows no. See, see this question. I think then it was 5 years maybe, right? Let's make this 5 because let's see. Abnormal insertion of terminal ureter, bladder colonization leading to recurrent UTI, delayed maturation of detrusor and sphincter control, occult neurologic lesion leading to disruption of bladder innervation, retrograde flow of urine from the bladder. The answer is C. Okay, I was right. It was 4 years. I thought that this is normal because everything was normal. But yes, I knew this, that 4 years. 4 years. So if it is greater, if the child is urinating at the night and he is less than equal to 4 years, that's completely normal. Okay, but as soon as the child becomes 5, okay, he should stop. Okay, but here he is still, so there is a delay maturation. I was right. If here they would have given that this is normal, maybe I would have selected that because the bias which came into my mind when I saw everything was normal. But again, trust your knowledge. See, I knew the 4-year mark. Okay, but yeah, the answer is C. This is for sure. Next questions. Okay, so pause the video. We'll first do this. Let's move it. The most appropriate pharmacotherapy for this patient is from which of the following classes of drug? Okay, so they have not given you drugs, they have given you the classes. I think they have tried to make it a second order question by this. Okay, let's see. A 45-year-old woman is brought to the ED 30 minutes after sudden onset of crushing chest pain. Okay, rates 10/10. So this is MI. She takes no medication, no substance, pulse is high, systolic blood pressure gone, tachycardia is there, ST segment elevation. So this is STEMI in the V1 through V3 anterior wall MI, ST depressions in. Remember, if there was ST segment elevations in AVF, then we would have thought it to be a right wall MI. Okay, and here you can not use nitroglycerin. You can, and you have to give IVF. Usually in MI we don't, but in a right wall MI, which will be indicated if there is ST segment elevations in AVF. Okay, so yeah, if AVF has ST segment elevations, that means it is our right sided MI. The possibility increases for STEPS exams. So don't give nitroglycerin, do not reduce the preload, and the treatment will be increase the preload by giving IVF. This is just a important concept which I thought I can tell you here. Okay, the physicians plan to administer a drug to increase the patient's blood pressure. Of course, the blood pressure is very low without increasing her pulse. That also makes sense because the pulse is high. The most appropriate pharmacotherapy. Okay, so let's eliminate here. Let's start from A. Alpha adrenergic agonists. Yes, it will increase the blood pressure and it will reflexly decrease the pulse, slow the heart. This can be the correct answer. Let's see if there is some drug which is not affecting the pulse. Antagonist cannot be there. Okay, vasodilator. Agonists, no. This both antagonists and agonist will be vasodilator. Beta adrenergic antagonist. No, dopamine is the best drug to increase the heart. Dopamine, dobutamine, will read no. So this cannot be the answer. Answer is A. Okay, don't select dopamine agonist for God's sakes, because it fasters the heart rate. It is the best drug to given to increase the pulse. Dobutamine, dopamine. Okay, so the answer is A here. Okay, for sure. Next question. Pause the video if you want. Let's start. Which of the following is the most likely embryologic origin of this patient's condition? Okay, a 5-year-old girl is brought to the ED because of 2-day history of fever, urinary urgency, and burning pain with urination. She has 4 similar episodes during the past year. A diagnosis of UTI is made. 4 episodes of UTI is there. Okay. Subsequent renal ultrasonography shows one large U-shaped kidney. Okay, like this. Which of the following is most likely embryologic origin of this patient's condition? Turner syndrome, maybe she has. Failure of the kidney to rotate, no. Failure of the normal kidney ascent, can be. Failure of one ureteric bud, no. Fusion of the inferior, this is the answer. Fusion of the inferior poles of the metanephros during ascent, because of which ascent was not completed. Okay, yes, answer is T. Okay guys, so yeah, 5 questions for today. Yes, I don't have any more. If you want, I can make subsequent videos on more questions like this. Let me know how many questions you got right or wrong. Okay, what was your score out of 5? And let me know that whether I should make more videos like this. Did this help you? Okay, so yeah, let me know that. See you in the next video. Bye.